Good day, dear students. Today we have a lecture about anemia. So I want you to mark yourself in chat. I want to see who is present today. I will start, and I think that information in my lecture will be useful for you for further learning of internal medicine. So, erythropoiesis, it's quite a difficult process in which a lot of organs and systems take place, and you see in this picture how difficult it is and what are the main stages maybe of erythropoiesis in our organism, in human organism. So what is anemia in general? Anemia is a decrease in the number of red blood cells, and due to it we see decreased oxygen carrying capacity and all clinical signs and symptoms of anemic syndrome. So remember, anemia is a simple decrease in the number of red blood cells. What are the main mechanisms of anemia? So there are three main. It's blood loss, which can be acute and chronic, and deficient erythropoiesis, and excessive hemolysis, when we see RBC destruction. How we may find anemia in our patients? So it's quite simple, it's quite routine test. So we need to understand that patient has problem with erythropoiesis. So we'll check red cell count, we'll check hematocrit, and we'll check red cell hemoglobin content. And you see that in men we may say about anemia if hemoglobin is less than 140, hematocrit is less than 42%, and RBC is less than 4.5 millions. And in women the markers of anemia is near the same, so you see that decreasing of hemoglobin is less than 120, hematocrit decreased till less than 37%, and RBC is less than 4 millions. So what I want you to remember, that anemia, it's not a disease. There are a lot of conditions which follow and lead to anemia. So if you see patient with these changes in common blood test, you must try to find the underlying disorder, and when you find it, so your task is to treat this underlying disorder. Of course, anemia you will treat using replacement therapy or some other methods. We'll discuss it later, but in general, if you see these signs, you must find underlying disorder which lead to anemia. So there are, as I said, three main mechanisms of anemia. Now I'll tell you in some details about these mechanisms and examples of them. So, as I said, blood loss, maybe it's the most often mechanism of anemia. It can be acute, it can be chronic. Of course, we see anemia more often in chronic blood loss. So in acute, it's different bleeding. More often it's GIT bleeding, it's injuries, sometimes in childbirth due to trauma, for example, or after surgery. And chronic blood loss we may see in such cases as bladder tumors, in different tumors in general, in GIT or polyps, in heavy menstrual bleeding in women, in kidney tumors, and of course widespread pathology, it's ulcers of stomach and sometimes duodenum or small intestine. So besides blood loss, we said before about deficiency of erythropoiesis. So when we see deficient erythropoiesis, more often we see microcytic form of anemia, and the main examples are iron deficiency or different problems with iron metabolism in organisms. So it can be due to iron deficiency, iron transport deficiency, iron utilization defect, iron reutilization defect, so different variants of iron disorders of iron metabolism in human organism. Also, we may see this form of anemia in patients with thalassemias. Due to this deficiency of erythropoiesis, also anemias can be normochromic and normocytic. So it's, as you know, I think, it depends on the color index and the sizes of erythrocytes. So normochromic and normocytic, normal sizes and normal concentration of hemoglobin in erythrocytes. So we may see this form of anemia in patients with aplastic anemia, in the cases of hyperproliferation, in chronic kidney disease, in some endocrine pathology, in myelodysplasia or myelophthisis. And sometimes they can be microcytic. We see such forms of anemia in patients with some deficiencies, for example, vitamin B12 deficiency, which is more often in our patient, or folate deficiency, or sometimes in copper and vitamin C deficiency. So one more time, it's deficiency of erythropoiesis. So it can be microcytic, normocytic, and macrocytic. Another mechanism of anemia is excessive hemolysis due to different extrinsic defects. So we may see it in hypersplenism, when function of spleen is increased. We may see it in different immunologic abnormalities like autoimmune hemolysis, in case of gold antibody hemolysis or warm antibody hemolysis, or sometimes more rare is immune hemolysis. So we'll discuss it later for your better understanding what is it. Also sometimes due to mechanical injury, also excessive hemolysis can take place in traumas or some infections. And excessive hemolysis due to intrinsic factors. There are some different membranopathies. So it can be acquired, or they can be acquired, or congenital. You see that membrane alteration which are acquired in hypophosphatemia, paroxysmal nocturnal hemoglobinuria, or stomatocytosis. We may see membrane alteration which are congenital. It's hereditary elliptocytosis and spherocytosis. And there are some rare forms. I think that if somebody from you will decide to be hematologist, you will know what rare forms of anemia due to intrinsic RBC defects we have in our practice. So, and different hemoglobinopathies, which also sometimes we may see in our practice. It's hemoglobin C disease, hemoglobin E disease, so different of them, sickle cell disease, thalassemias also. So these are the main mechanisms and they're examples of different forms of anemia. So as a short conclusion, we may divide all anemias to three main forms: post-hemorrhagic, due to blood loss, impaired RBC production, and increased RBC destruction. What should we do in case when we see the patient with the changes in common blood tests, about which I told you before? So when we see decreased concentration of hemoglobin in erythrocyte, when we see decreased general quantity of erythrocytes and decreased reticulocytes. So we should start from history and family anamnesis of patient. There are some congenital anomalies about which I said before, and sometimes you may find necessary information about congenital anemias due to history report and family anamnesis of your patient. Of course, some physical examination we need to understand the severity of anemia and those underlying disorders which lead to anemia. And of course, laboratory tests which are the most informative maybe for us, and using them we may differentiate different forms of anemias. So what are the main laboratory tests? Of course, CBC with white blood cells and also platelets, RBC indexes and morphology, reticulocyte count, peripheral smear, and sometimes for differentiation we need to make bone marrow aspiration and biopsy. If about CBC and RBC indexes and morphology, I think you already know what is it. I want to give you some more information about other indexes, but in general, let's start from history and anamnesis of patient's disease. So if we see patient with vegan diet, we may think about possible vitamin B12 deficiency. If we see the patient with alcoholism in anamnesis, we should think about folate deficiency. In some patients who need to take drugs or after some severe infections, we may think about possible hemolytic genesis of anemia. And in some chronic diseases like severe diseases like rheumatic disorders, different chronic inflammatory disorders, in chronic kidney disease and in cancer, we should think about suppressed red cell production. And this information will help you to make differentiation in early stages of patient's investigation. So, as I said, I will tell you about some specific markers which will help you also to differentiate different variants of anemia during your first meeting maybe with the patient after simple analysis. So reticulocyte count, it's quite informative index which help you to understand what is the response of bone marrow to, for example, any kind of injury or pathogenetic or etiological mechanism. So in general, reticulocyte count, it's the percentage of reticulocytes. You see the normal borders and absolute, or also it can be evaluated in absolute reticulocyte count. You see the quantity of reticulocytes which is normal. So due to this index, we may understand, as I said, response of bone marrow and functioning of bone marrow in general. And also you know the reticulocyte count can be useful for you for differentiation between different mechanisms of anemia, between deficient erythropoiesis, when there are changes of RBC production, and excessive hemolysis, when there are increased mechanisms of RBC destruction. So reticulocyte count is quite important index which you should investigate and know to further diagnosis and differential diagnosis, because as you saw, there are a lot of different forms of anemias, and simple CBC and sometimes it's not enough to understand, so you may use reticulocyte count, and you must use this marker. And more rare analysis, but sometimes we should perform it. And of course it gives you additional information, and after that you may put correct diagnosis if before you had some doubts. So bone marrow aspiration and biopsy. So there are some indications for this investigation. We should do it when we can't find the real reason of anemia. So anemia is unexplained. You can't understand why it's present. So if you have doubts after previous investigation, then if you see that besides anemia, patient has also thrombocytopenia with leukopenia, or in combination or separately. So anemia plus thrombocytopenia or plus leukopenia, or both of them. And of course biopsy of bone marrow will help you to put the correct diagnosis if you suspect primary bone marrow disorders like multiple myeloma, like myelodysplastic syndrome, metastatic disease, myelofibrosis, different kind of leukemia. So here you see the main indications for bone marrow aspiration and biopsy. Of course, not for all patients with an anemia we should perform this investigation. So, in general, in our practice, more often we see the patients with iron deficiency due to blood loss, as I said before, and anemia of chronic disorders, which take place in different persistent infection, inflammation process, in malignancy. So these are the most often reasons of anemia which we see in our patients. One more time, and also some key positions, maybe keywords about each form of anemia. So as we said before, anemia can be due to blood loss, which can be acute and chronic. So we should differentiate them between each other and with other anemias. You see that in acute blood loss, erythrocytes are normochromic and normocytic. In severe cases, we may see nucleated RBCs and left shift of white blood cells, and sometimes leukocytosis and thrombocytosis, which show us a disaster in organism, because blood loss, it's a disaster. So blood loss which is chronic has some has another manifestation, as in morphological changes and in specific features of this condition. So for chronic blood loss, we see microcytic forms of erythrocytes with anexa and poikilocytosis. We see reticulocytopenia in bone marrow hypoplastic process with delayed hemoglobination. And the special features of chronic blood loss is possible or hypochlorhydria, smooth tongue and spoon nails, absence of stainable marrow iron, low serum iron, increased total iron binding capacity, and low serum ferritin, which show us deficiency of iron. Of course, they are very near to each other: blood loss, chronic blood loss, and iron deficiency anemia. So iron deficiency anemia has the same morphological picture and mostly the same conditions and changes in blood indexes as in chronic blood loss anemia. Also, there are some deficiencies which lead to anemia, and more often we see them due to folate deficiency and vitamin B12 deficiency. So for folate deficiency, in CBC we see oval microcytes, also anisocytosis and reticulocytopenia, hypersegmentation of white blood cells, and megaloblastic changes in marrow. And some specific changes which help you to detect folate deficiency: it's decreased level of folate in serum and in red blood cells. And of course, as we said about underlying disorders which lead to anemias. So if for folate deficiency, we may see that patients suffered for years from sprue, from celiac sprue, because of pregnancy. Sometimes in alcoholism we see folate deficiency, or in children also sometimes when there is very intensive growth in infancy. Vitamin B12 deficiency we may see in autoimmune atrophic gastritis, as you know, I think. So in CBC there will be oval microcytes, also anisocytosis, the same reticulocytopenia and hypersegmentation of white blood cells, and megaloblastic marrow. And to detect vitamin B12 deficiency, we should detect level. We should check level of serum B12. Check different changes in gastrointestinal tract, in central nervous system, because there are some specific signs of B12 deficiency. We may see also elevation of serum bilirubin in this patient and increased lactate dehydrogenase level. If it's due to atrophic autoimmune gastritis, so we may check for antibodies to intrinsic factor in serum for pernicious anemia, or sometimes absence of this gastrointrinsic factor secretion, also due to severe atrophy of gastric mucosa. So another etiology or type of anemia is hemolysis. So in hemolysis we may see normochromic and normocytic anemia with reticulocytosis, so bone marrow response is good and increased sometime, and marrow erythroid hyperplasia also is specific for hemolysis. Some specific features of hemolytic anemia: it's increased serum indirect bilirubin due to destruction of erythrocytes and hemoglobin, and lactate dehydrogenase level, increased stool and urine urobilinogen, because it needs destructed hemoglobin need to be metabolized and evacuated from the organism, and hemoglobinuria in fulminating cases, and hemosideриnuria. So, as I said, there are some anemias due to chronic diseases, like different chronic infections or severe infections, maybe acute, due to cancer, and due to some chronic inflammatory process in organism. So, these kind of anemias more often are normochromic and normocytic. Later it can become microcytic. More often there is normoblastic response of bone marrow and normal iron indexes, iron stores. Additional investigation will show us that patients with chronic diseases and anemia has decreased serum iron, decreased total iron binding capacity, and mostly normal serum ferritin and normal marrow iron content. Some more anemias which are more rare than previous, but you should know that you also can see it in your practice, and you must know what to do with this patient. So hereditary spherocytosis, what we see in CBC, there will be spheroidal microcytes. It's normoblastic erythroid hyperplasia in bone marrow, and reticulocytosis is typical. And we see increased mean RBC hemoglobin level, increased RBC osmotic fragility, shortened survival of labored RBC. So it's specific investigations which we need to perform to detect this form of anemia due to spherocytosis. Another variant of anemia is sickle cell disease. So we'll see in CBC anisocytosis and poikilocytosis, of course some sickle cells in peripheral smear, sickling of all RBCs in preparation with hypoxia or hyperosmolar exposure, and reticulocytosis is typical for sickle cell disease. So as specific features, you see that they can be detected hemoglobin S during electrophoresis, largely limited to blacks. There will be urinary isostenuria, it's typical for them, and possible vaso-occlusive crisis and leg ulcers can be present, and sometimes bone changes on X-ray, which also will help you to differentiate this form anemia from others. Another variant of anemia is marrow failure. So later we'll discuss aplastic anemia. So what we see? We see nomochromic and nomocytic form of anemia, sometimes maybe macrocytic. We see poor response of bone marrow due to low reticulocyte count, so reticulocytopenia is typical. Failed marrow aspiration or evident hyperplasia of erythroid series or of all elements of bone marrow can be decreased, all of them. And what we know about marrow failure, that more often it's idiopathic, we can't find the real reason of it, and near to 50% without any visible reason. And secondary, sometimes due to some toxic drugs or chemicals, due to occupational hazards or due to intake of some drugs, so we may see depression of marrow functioning. Also, we should remember about marrow replacement, which we call also as myelophthisis. What is it? So we see marrow infiltration with infectious granulomas, tumors, fibrosis, or lipid histiocytosis. So we may see hepatomegaly and splenomegaly in this patient, and sometimes possible bone changes. And in CBC, anisocytosis and poikilocytosis also, nucleated red blood cells, early granulocytes precursors, and bone marrow aspiration possible show you underlying diseases like leukemias or myeloma or metastatic cells. So it's replacement of bone marrow by abnormal cells due to leukemia or, as I said, myeloma or metastatic cells. So this situation you will see in patient with malignancy. Also some words about rare forms of anemia: cold agglutinin disease, paroxysmal nocturnal hemoglobinuria, and sideroblastic anemia. So you see the main morphological changes and some specific signs of these diseases. I think that will continue, and if you will have, or if you want to know about these anemias more, I think that you will have enough time to read it. And now we must discuss more often forms. So, iron deficiency anemia. You see that iron metabolism, it's quite difficult process, and you see the main stages of its absorption and what additional factors, nutritions we need to improve absorption of iron. So the iron absorbed, as you see, in duodenum and upper jejunum. That's why if there are some problems in these organs, we may see malabsorption and in a time deficiency of iron. Iron absorbed better from nutrients, from meat. That's why if you see patient with anemia, diet which is rich of meat products, it's good, it's more physiological to improve, to increase iron capacity of patient's organism. We need ascorbinic acid to improve absorption. That's why for treatment we prescribe as replacement therapy not only iron but in combination with ascorbinic acid. And you see that the storage in organism of iron is iron is present in different substances. You see body iron is spread in such way. So in hemoglobin in men and women you see 2 and 1.5 gram ferritin, then hemosiderin in myoglobin, in tissue enzymes and transport ion compartment. So you see where iron take place, in what processes, in what biochemical substances. And how the human organism store iron in general. So what about iron deficiency anemia? Blood loss is most often cause of iron deficiency anemia. So as we said before, it can be acute and chronic, so more often it's chronic occult bleeding. Sometimes we may see it in premenopausal women which have, due to their life, due to menstruation, they have deficiency of iron for years. In some cases we may see such form of anemia due to chronic intravascular hemolysis or due to vitamin C deficiency. When there are some, due to vitamin C deficiency, we see increased capillary fragility, also hemolysis and small bleeding. Also anemia, iron deficiency anemia can be due to increased iron requirements. So in a young aged patient, in children, during adolescent, human organism needs more iron. That's why if there are some changes in diet, for example, poor diet, poor with meat diet and a rapid growth, sometimes it can be not enough concentration and not enough level of iron which patient take. During pregnancy also there is increased needs for iron in organism. We may see also problems in iron absorption. So it can be decreased due to gastrectomy, due to different diseases, for example gastric cancer or hypertrophic form of gastritis, or in some small bowel malabsorption syndromes. So when there are problems in iron absorption. To detect iron deficiency anemia, we need to perform some tests. So these are specific tests which help you to detect iron deficiency anemia. They are complete blood count, so routine test, serum iron to detect deficiency of iron in organism, iron binding capacity, serum ferritin, transferrin saturation, reticulocyte count, red cell distribution width, and peripheral blood smear. Sometimes in rare cases when we have some doubts about possible mechanism of anemia, and as we said, for example, if anemia accompanied with thrombocytopenia or leukocytopenia, we need to perform bone marrow examination and detect the real reason of anemia. So these are the normal borders of iron in human organisms. So you check serum iron, total iron binding capacity, ferritin and transferrin saturation, and it will help you to differentiate different stages of iron deficiency anemia and in general iron deficiency in organism. So in general there are 5 stages of iron deficiency anemia. So of course we see our patient, then they have already 3rd, 4th or 5th stage. In 1st stage we may see only decreased bone marrow iron stores, and mostly all routine indexes are normal, so no complaints and patients mostly healthy. The 2nd stage, it's already some problems with erythrocyte, with erythropoiesis. So some specific tests will help you to reveal this, to detect this stage of anemia. Of course, in our routine practice, we see anemia already in these stages. So stage 3 it's anemia with normal appearing RBCs and indexes, and 4th stage it's microcytic anemia already, and hyperchromia we'll see, and severe form of anemia it's stage 5, when we see already affection of tissues and all good known symptoms and signs of anemia. So one more time, causes of iron deficiency: it's chronic blood loss, it's menses, it's acute blood loss, it's blood donation sometimes, it's phlebotomy in treatment of polycythemia vera, it's situation in rapid growth in infancy or adolescence, in pregnancy, and erythropoietin therapy. And decreased iron intake or absorption due to inadequate diet, due to malabsorption as we said before, and due to malabsorption due to surgery or diseases. The main symptoms of anemia are fatigue, loss of stamina, shortness of breath, weakness, dizziness, paleness, restless leg syndrome. So quite unspecific signs, but most of them are present in patients with 4th or 5th stage of anemia. Also there is so-called sideropenic syndrome, when we see, due to iron deficiency, connective tissue dystrophy. You see changes of nails, concave nails, as we call it, koilonychia. We may see, or patient can suffer from dysphagia. There can be present smell and taste disorders, glossitis, cheilitis, and sometimes in severe anemia, muscular and sphincter weakness. What are the main tasks of treatment? So, if you didn't find the underlying disorder which lead to anemia, iron deficiency anemia, and you will give only iron without pursuit of cause of this iron deficiency of iron, of course no good result of your treatment you will achieve. So if it's bleeding, and we said that chronic bleeding is the most often reason of iron deficiency, you should examine the patient properly and find the real cause of iron deficiency in your patient. For replacement therapy we use different salts of iron. More often we use ferrous sulfate, but it can be also gluconate and fumarate. So we recommend it to take before meals, but sometimes iron can irritate gastric mucosa, and patient will have some unpleasant discomfort in abdomen due to intake of iron. That's why it's very individually, but in general, the most we should recommend take iron for better absorption before meals. And the typical initial dosage of iron is 60 milligrams of elemental iron. In general, for ferrous sulfate, it's 325 milligrams once a day or twice a day, it depending on the severity and tolerance for iron containing drugs. In severe cases, we need to use parenteral iron, but in general, we need to better to use oral intake of iron because the side effects of parenteral iron sometimes are very severe, and if there are no direct or absolute indications for parenteral iron, you start treatment of iron deficiency from oral intake of iron salts. As I said, for improvement of iron absorption, we need to combine it with ascorbinic acid. Sometimes we may give it in pills, or sometimes we may use some products, or for example orange juice, to give patient additional portion of ascorbinic acid. It will increase absorption and have less gastric distress. If you decided to prescribe parenteral iron, you should ask for the dosage of hematologist. So prescription of and dosage of parenteral iron is determined only by hematologist. So if you are physician, of course, no parenteral iron treatment. And the duration of replacement therapy of oral or parenteral iron should continue for more than 6 months after you correct the normal level of hemoglobin. So we need to replenish tissue stores of iron. So treatment of iron deficiency is quite prolonged, and normal CBC, it doesn't mean that you should stop replacement therapy of iron. So the main also orally iron salts given before 30 minutes before meals. The typical dosage you see near 60 milligrams. To increase larger doses of iron may provoke some GIT discomfort and problems, and ascorbinic acid is necessary to improve absorption of iron. So another big group of anemias is anemia of chronic disease. So I said about it before. So it's more often it's nomocytic. Sometimes it can become microcytic. So it's in CBC. You may see these features. As I said, more often it's accompanied some infections, some inflammatory process, for example, rheumatoid arthritis, or non-specific intestinal inflammation, and cancer. So in this group of patients you may see nomocytic anemia, and you must understand that it's due to these chronic diseases. The underlying diseases are infections, cancer, and chronic inflammation in organism. So what are the main pathophysiological mechanisms of this anemia? A shortening of RBC survival. Erythropoiesis will be changed due to decrease of erythropoietin production, and sometimes marrow responsiveness to erythropoietin, and iron metabolism, intracellular iron metabolism, also can be impaired in this patient. You should put this diagnosis, of course, due to symptoms and signs of underlying disorder, so the symptoms and signs of main disease. You check CBC, of course, serum iron, ferritin, transferrin and transferrin receptors to differentiate it from iron deficiency. And you see that if hemoglobin usually is not very low, and in general serum ferritin levels are also quite normal unless iron deficiency is present, because of course if it's inflammatory bowel diseases, so in a time there will be anemia also due to deficiency of iron, for example. So how we'll treat it? So of course we treat the main disease. We use recombinant erythropoietin and sometimes iron supplements if we see already deficiency of iron in organism. You see the dosage of erythropoietin and the dosage of iron we discussed before, they are the same. So it's a combination of erythropoietin and iron in most cases. Another big group of anemias which take place in our patients, it's megaloblastic anemias. So what are megaloblasts? It's a large nucleated RBC precursors with non-condensed chromatin. Megaloblastosis precedes microcytic anemia, and microcytes, it's enlarged RBCs. So in common blood test, common blood count, you will see megaloblasts and microcytes. More often this kind of anemia, megaloblastic anemia, it's due to take place due to deficiency of vitamin B12. So we may see it in inadequate diet, also in vegans, in breastfeeding women, and infants of vegan mothers, and fat diets. Also it can be due to impaired absorption. So in atrophic gastritis, as we said, decreased level of intrinsic factor lead to abnormal absorption of B12, and we may see this condition in patients with also with gastric surgery, with gastric bypass surgery, so not only in autoimmune atrophic gastritis. Sometimes can be inhibition of intrinsic factor, sometimes decreased acid secretion will also disturb absorption of vitamin B12, and some small bowel disorders which lead to malabsorption. For example, inflammatory bowel disease, celiac disease, cancer of in GIT, and some biliary and pancreatic disorders. Also, patients with AIDS suffered from B12 deficiency, vitamin B12 deficiency, and some inadequate utilization of B12, so some enzyme deficiency, liver disorders, transport protein abnormalities, and due to some drugs which also interact with, which also can disturb absorption of vitamin B12, such as anticides like metformin, and you know that metformin is a very spread drug for the patients with diabetes mellitus and insulin resistance. So monitor patients' CBC in patients with prolonged intake of metformin. And sometimes nitrous oxide repeat exposure can also lead to vitamin B12 deficiency. Also, megaloblastic anemia can be due to folate deficiency. So we may see folate deficiency in diet lacking fresh green vegetables or enriched grains, chronic alcoholism, in total parenteral nutrition for severe patients. Sometimes also in celiac disease, PRU, or different malabsorption syndromes, and some also drugs may disturb absorption of folate, such as all the same metformin, some anticonvulsants, methotrexate. So monitor level of folate in patients with these diseases and which need to take these drugs for a long period of time. So megaloblasts results from defective DNA synthesis. That's why in megaloblastic anemia we see that all cell lines will be disturbed. We will see dysbiosis of all cell lines. Dysbiosis results in intramedullary cell death, making erythropoiesis ineffective. And we see not only anemia, but we see reticulocytopenia, leukopenia, and thrombocytopenia, which may develop in a time due to B12 and folate deficiency in megaloblastic anemia. What are the main clinical signs of these diseases? It's pale icteric skin, peripheral neuropathy can take place, dementia, gray hair, huntoglossitis you see in picture, and some GIT disorders, diarrhea. Diarrhea also take place in these patients because of GIT affection. Some pictures of megaloblastic anemia. So how we'll put diagnosis of megaloblastic anemia? So in CBC we see enlarged erythrocytes. In bone we make bone marrow aspiration with biopsy if we need to differentiate, as I said before. We should check, of course, the level of serum folate and vitamin B12. We should check GIT to understand what is the possible mechanism of malabsorption, and some food globin malabsorption tests which will help us to detect this malabsorption. So in CBC, macrovalocytes, anisocytosis and poikilocytosis also can take place. The specific sign is holy jolly bodies. What is it? It's residual fragments of nucleus, and it's a typical sign of megaloblastic anemia. We see reticulocytopenia because there is a poor response of bone marrow. We see hypersegmentation of granulocytes, and in a time we may see neutropenia, as we said, and thrombocytopenia because all poiesis is disturbed. I think that you heard before about Schilling test. So this test we use only for detection of classic pernicious anemia, when we see deficiency of intrinsic factor due to atrophy, for example, or absence of the stomach after surgery. So you see the procedure, you see how we should understand the results of this test. So now it's not very spread, but in general you should remember that it's specific test for classic pernicious anemia. How we'll treat the patient with megaloblastic anemia? Of course, as we said, that anemia it's a syndrome, it's not a disease, and in each case we should detect the underlying disorder. We find the underlying disorder and treat it. So treatment of main disease. Of course, supplementary therapy because it's deficiency. So we prescribe vitamin B12. You see the dosage. It can be orally, or sometimes it can be parenteral intake. The dosage is depending on the severity of deficiency and clinical manifestation of anemia and accompanied problems. In severe deficiency, as you see, intramuscular injections, the duration is sometimes months or 2 months, so it's depending on the response and the possible treatment of underlying disease. And if we detect folate deficiency, you see the dosage of folate, which we also give orally. It's more physiological and it's enough for replacement therapy. Hemolytic anemia. So, general features and general mechanisms of hemolytic anemia. So, it can be, as I said before, due to disorders of extrinsic RBCs. So, reticular endothelial hyperactivity we may see in patients with hypersplenism, for example, in liver diseases, in cirrhosis, so can take place. Some immunological abnormalities, as we said before, also warm antibodies, hemolytic anemias, cold antibodies, paroxysmal cold hemoglobinuria, so different autoimmune hemolytic anemias. Some infections can lead to hemolysis. Some toxins of infection organism can lead also to hemolysis. Some mechanical traumas can lead to hemolysis. So also anamnesis will give you sometimes very useful information about possible genesis of anemia if you think about hemolysis. You see that some toxins also provoke hemolysis, and you see intoxication by copper, by lead, some insects and snakes venom may lead to hemolytic anemia. So we discussed it before. I think that it's not necessary to repeat it now one more time. So you see that there are some membranopathies which lead to hemolysis, and some hemoglobinopathies also, like you see in the lower part of this table. So hemolytic anemia, why can be, what kind of hemolysis can be? It can be acute also, it can be chronic, and it can be episodic. So we may divide hemolysis in these three main variants. Also, it can be extravascular and intravascular, and in some cases both of them in the same patient. So you see the variants of RBC morphology in different forms of hemolytic anemias, and I think you will discuss it in more details in your practical classes. Let's continue with symptoms and signs. So, of course, if we say about anemia, there are systemic manifestations which are the same as for all other forms of anemia. It's pallor, fatigue, dizziness, and possible hypertension. So if we say about hemolysis, we should remember about possible hemolytic crisis. They can be acute and severe, and sometimes accompanied with chills, fever, pain in back or abdomen, and sometimes in severe cases accompanied with shock. Patients with hemolytic anemia often, due to severe hemolysis, can have jaundice, and we may see splenomegaly during examination of our patient. And due to hemoglobinuria, we may see red or reddish-brown discoloration of urine. Then you check the same CBC, peripheral smear, reticulocyte count, serum bilirubin, lactate dehydrogenase, and transaminases. Sometimes you may check the level of urinary hemosiderin and serum haptoglobin. In some cases, you may use erythrophoresis of hemoglobin to detect what kind of hemoglobinopathy your patient has. Some flow cytometry called agglutinins, osmotic fragility check, so some specific tests which help you to detect what is the main mechanism of hemolysis in this concrete patient.
So we should differentiate hemolytic anemias between them and with some other anemias. So some morphological changes in some hemolytic anemias. For example, spherocytosis. What we see? What are the causes of it? So transfused blood, we may see hemolysis, we may see warm antibody hemolytic anemia and hereditary spherocytosis. In these cases we see these changes of morphological changes of RBCs. In microangiopathy and intravascular prosthesis, we may see schistocytes in CBC, in peripheral smear. Target cells, they are typical for liver dysfunction and different hemoglobinopathies. Sickle cells, it's a classic typical sign of sickle cell disease. So agglutinated cells we see in cold agglutinin or warm agglutinin diseases, and some other variants which also can take place in hemolytic anemia. So how we'll treat hemolysis? Of course, it depends on the mechanism of hemolysis. So in some cases we need iron replacement therapy if we see hemoglobinuria and hemosideриnuria, when patient has loss of iron after hemolysis. In some patients, when hemolysis takes place due to immune response or autoimmune reaction, we need steroids. In some patients, to prevent hemochromatosis, we need chelation therapy. If patient need long-term transfusion therapy because of chronic hemolysis. To prevent accumulation of iron in tissues. In some cases, in some hemolytic anemias, we may use surgery, for example, splenectomy, but because it's surgery, you must be very you must differentiate and trying to find all conservative methods which also can be useful, because splenectomy will lead for some further problems in patient's organism. That's why in some situation it can be helpful, but in some situation it can be dangerous also. So you remember about splenectomy, but of course first must be conservative treatment. If hemolysis is connected with cold reaction, so of course keep patients warm, and it will prevent cold agglutinin crisis in this patient. And also for patients with chronic long-term hemolysis, not only iron replacement therapy, but in a time we need folate replacement therapy also to improve erythropoiesis. Another group of anemias are aplastic anemia. So in general, as we said before, near to 15% of this form of anemia it's idiopathic. So we can't understand and find the real reason of this bone marrow failure. So more often we see it in adolescents and young aged patients. In half of patients we may find the secondary mechanism of marrow failure, and more often it's due to some chemicals, benzene, inorganic arsenic, sometimes in radiation exposure and in some drug intakes. In general, mechanism is unknown, but these harmful substances depress bone marrow functioning. So the result will see clinical manifestation of aplastic anemia. So it also can be acute, it also can be chronic. So acute also can be due to different acute viral infections, or in children we may see it. Chronic is more often due to autoimmune mechanisms, different drug intakes, also the same toxins. And in chronic lymphocytic leukemia also as myelofibrosis, but in general it's another mechanism, we'll discuss it later. More mechanisms of aplastic anemia. So you see some diseases, some conditions which also may lead to aplasia and bone marrow depression. So what are the criteria of aplastic anemia? More often it's normochromic and normocytic. Because all poiesis is disturbed, we see pancytopenia in CBC. This form of anemia is regeneratory because of reticulocyte count indexes. We see that they are very low, reticulocytes, so low response of bone marrow. We see that serum iron is increased, so there is no deficiency of iron. We see low cellularity in bone marrow biopsy, and disappearance of red bone marrow in trypanosome biopsy will also help you to differentiate aplastic anemia from other forms of anemias. The symptoms and signs are quite unspecific, so it depending and varies due to severity of pancytopenias. Non-specific signs of anemia, as we said before, also will be present, and it depends on the severity, also the manifestation of general symptoms of anemia. In some patients we may see hemorrhagic syndrome due to thrombocytopenia with petechias, ecchymosis, bleeding from gums. This patient more often suffered from some infections because of agranulocytosis. We mostly never see splenomegaly in initial stages of disease, but it can appear later due to hemosiderosis, and in general, all symptoms are depending on the severity of anemia and pancytopenia. So, to put diagnosis, common blood count and reticulocyte count with poor regeneration, and bone marrow aspiration with depressed all of poiesis. So, aplastic anemia is suspected in young patients with pancytopenia. We see that bone marrow cellularity is decreased, and you see the markers of neutrophils changed count, of absolute neutrophil count, of absolute reticulocyte count, and platelet count, which also must be present and show you that patient has aplastic anemia with pancytopenia. So it's not only erythrocytopenia, it's pancytopenia, because all cells, blood cells, will be depressed, production of them. So treatment is quite difficult, because, as we said, in general, in half of the patients we don't know the real reason. If we know reason, we try to avoid it. But in general, treatment of aplastic anemia is hematopoietic stem cells transplantation, and immunosuppressants can be sometimes useful with equine thimeroside globulin and cyclosporin. So sometimes we need both, so we use combination of these methods. Sometimes it can be separately. But in general, the prognosis for the patient's life and flow of disease is not very good in the case of aplastic anemia, and as you see, treatment also is very specific and sometimes not very effective. So thank you for your attention. I hope that the information was interesting and it will be useful for you for preparation for your practical classes and maybe for your further practice. Goodbye.